case number one. It's a case of a partial articular supraspinatus tendon avulsion. Here we have a patient. He's 38 years old. He's a recreational athlete. He's had 9 months of shoulder pain. He's failed NSAIDs. He's failed physical therapy. On physical examination, he's got good motion. He's got a small amount of weakness with external rotation, and he's got a mildly positive empty can sign. Diagnostic arthroscopy shows this left shoulder shows a articular-sided supraspinatus tear. So, the question is, what would you do with a POSTA lesion of this size in this patient? Do you follow the 50% rule that we've all kind of learned in our training? If so, I think it's important to have a good idea of the typical dimensions of the rotator cuff, which average about 25 millimeters from A to P and about 15 millimeters from medial to lateral. And then do you complete the repair or do you do an in situ repair? I'm going to show you a technique utilizing this anchor called the 3/0 knotless suture tack, and there'll be a new version of this, which is a threaded version, which is slightly larger, 3.9 millimeters, coming soon, which I think will make this even more appealing. What we're going to do is we're going to link our medial anchors. We're going to link the suture from the anterior anchor and compress that into the locking mechanism of the posterior anchor. And vice versa, we're going to take the suture from the posterior anchor and lock that into the mechanism of the anterior anchor. Here's the left shoulder POSTA lesion. What we're going to use is this trans-tendon technique utilizing the percutaneous insertion kit. This is a small kit that you can have them open. It has everything you need: the spinal needle, a nitinol that goes through the spinal needle, a dilator that goes over top of the nitinol, and then the inserter also comes in the kit. I place this right at the articular margin, even a tad bit onto the articular surface, because I want to get on the best bone possible. And I don't drill this, I tap this with an available tap that they have. We'll tap it into the bone. I typically only use this technique for your younger patients with really solid bone. And I'll place a second anchor in an anterior position. So now coming out of this anchor is a pull suture, which is the blue suture, and then there's a repair suture, which is your blue and white suture. So here we're taking the repair suture from the anterior anchor, and we're going to pull it into the splice locking mechanism of the posterior anchor. I'll tension it, but I won't tension it all the way. Now I'll take the repair suture from the posterior anchor and pull this into the splice lock from the anterior anchor. Now, before we really pull this down, I'll take those limbs and I'll pull them out laterally. What that does is that changes the trajectory of your pull so that you're not pulling directly in line with your insertion angle. And then we'll take a look at it. I'll cycle the anterior, posterior, multiple times until that rotator cuff is nicely compressed down against my medial footprint. And for additional fixation, if you want, you can place a lateral anchor and bring those suture limbs laterally, and you get a nice double row, cross row compression of this partial thickness rotator cuff tear. So case number 2. This case is a 17-year-old competitive baseball pitcher. He had no specific injury, but he had progressive pain with throwing for the past 7 months. He failed an appropriate therapy program, and I think the word appropriate is very important because when you're rehabbing pitchers, it's just not your typical therapy. You've got to do a lot of different things which are beyond the discussion of today, or of this talk. So on physical examination, he had some mild GERD or glenoid internal rotation deficit. He had normal strength, but he had pain with empty can testing. Here's his scope of the right shoulder. First, looking from the posterior portal, you see that fraying of the undersurface of the rotator cuff. And if we switch our view to the ASL or anterior superlateral portal, we can see that with abduction external rotation, this patient has significant internal impingement and abrasion of the undersurface of the rotator cuff, causing a partial articular-sided rotator cuff tear. So what do you do in this patient? Do you fix it? Do you debride it? Well, I think it's really important to remember that with these throwing athletes, if they ever want a chance of returning to their previous level of throwing, it's probably not a good idea to fix that rotator cuff tear. So we did a debridement in this patient. He went on, he played college baseball, and that's where he is currently. Case number 3, a bursal-sided rotator cuff tear. Here's the MRI, a 62-year-old active male, 4-month history of shoulder pain. He had failed all appropriate conservative treatment routes. He had good motion, but weakness with external rotation and a positive empty scan sign. So what do you do in this situation? The bursal-sideds are not as common as the posta lesions, but they're frequently more symptomatic and more painful than the posta lesions. We believe that they're probably associated more with impingement in these situations. And again, do you do an in situ repair or do you complete the tear? So we'll take a look at a bursal-sided supraspinatus tear and how we decide to treat that. So right shoulder, we're looking in the subacromial space from the posterior viewing portal. And you can see this measures approximately 10 to 12 millimeters from medial to lateral. And we're going to choose to do an in situ repair utilizing a speed fix technique. What we do is we place a fiber tape in an inverted mattress fashion. I'm using a spinal needle to determine what my appropriate anchor insertion trajectory is going to be. Sometimes that's through the lateral portal, but sometimes I believe it's better to make an alternate portal to put in your anchor. So we'll pass the one limb of the fiber tape, we'll pass the second limb of the fiber tape, and now we have this inverted mattress configuration. We'll pull both of those at the same time out our alternate portal off the lateral aspect of the acromion, and then we'll make our pilot hole on the lateral aspect of the greater tuberosity. We'll place our anchor down to the base of our pilot hole and compress those fiber tapes, and then we'll advance the swivel lock anchor, 5-5 swivel lock anchor in an interference fixation technique. Our interstitial rotator cuff tear. So here is an MRI. This one may be hard to find arthroscopically because it looks like it's got an intact bursal surface and an intact articular surface. It's a 47-year-old female. She had a year prior, she had a subacromial decompression, acromioplasty, biceps stenotomy by a reputable surgeon in town. She continued to have persistent pain, however. On her examination, she had good motion, but she did have persistent weakness with external rotation, and secondary to the biceps stenotomy, Sethi, she had a Popeye deformity. Just kidding. So interstitial tears, they're more common than the postas or the bursal-sided tears, it's believed. They typically occur between layers 2 and 3 of your rotator cuff, and likely they alter the biomechanics of the remaining tendon tissue on the tuberosity. Here's what we're going to do in this interstitial rotator cuff tear. So it's nice to get a feel of the rotator cuff, and I encourage you as you start your practice to palpate every rotator cuff from the bursal perspective to get a feel of what normal is. But this one just doesn't feel quite right. It feels like there's emptiness right underneath that bursal layer of cuff. So we'll place a spinal needle into that, what we believe is a defect, and we'll place some saline into that, and we see this, what we call a bubble sign. The cuff actually bubbles up, and you can see it actually extravasating from that small hole that we made previously with the spinal needle. And that's a good test for a potential interstitial tear. And if that test is positive, I typically go to the probe push, where I'll take a probe and I'll really try to push through that bursal layer. And if you just fall into emptiness, then that's another example or another indication that you have a substantial interstitial rotator cuff tear. So if you do, the only way to access that is to open it up, and typically opening up from the bursal side is the easiest and most efficient. And then we'll complete it with a speed fix repair. One last pearl that I'll give you on these interstitial tears is to do the bubble test from the intra-articular perspective as well. So if you're worried about it from an intra-articular perspective, you can place a spinal needle into what you believe to be the defect. And while you're looking inside, bring that spinal needle right to your capsule, your superior capsule, but not through your superior capsule. And then again, you'll take some about 10 cc's of saline. Just draw it from your arthroscopy portal is the easiest way to do it. And then you'll place that into your spinal needle while you're visualizing intra-articularly. And you'll see this bubble up, and it's a nice indication that you have an interstitial rotator cuff tear.